Okay, today we're going to talk about EMS systems, go over different things that you can find in the area, not just what's in Spokane, but around the country in general. So basically, when we're talking about an EMS system, we're talking about the personnel, equipment, the resources around the area that make up our emergency response outside the hospital system. But part of this is going to include those hospital resources of the ERs that we're going to be going to, and we'll talk about the Deaconess freestanding resources and other things as well. So when we talk about the in-hospital size, now we're talking about the emergency physicians, we're talking about rehab, we're talking cath lab, all those things inside the hospital that we're doing. So first responders are going to be everything from the police officers, firefighters normally, it can be lifeguards on there, can be teachers in the high school, um, and then we're going to have different tiered response of whether we have a transport EMS service like we have in KCFR in Kootenai County, or whether it's going to be a fire department and a transport agency. Here we have to decide what kind of facility do we need to transport to, where we're going to transport, closest time, a lot of different factors that comes in and what our protocols come to. So all this was developed in the United States based on several different factors. So we're going to talk about the history and what developed everything. So it really started long time ago. You could go back to as the first techniques, and I'm really not going to go too much into the history, but you can read in here in the slides and actually spend a little bit more time talking about this. Realistically, in war, they talk about the Napoleon years. It was even before that, but that's when we really started talking about getting people taken care of, and then that extended into, again, out of our wars, military, and that is where a lot of our stuff for EMS really comes to. A lot of our protocols are going to be driven out of that as well. Triage really came out of the Civil War, where we talked to it in a standard. But there was a lot of things, and that's where even today, and we'll talk about through this course, how there's so much different things that are coming out of our wars and basically out of our military and having to do things in those environments that we're really using in our EMS. Again, it's more related to our trauma, traumatic arrest, and those kind of things, but unfortunately, we're using almost our military as a testing ground for a lot of the things that we're doing right now. And this pretty much, as you'll see as you're reading all these slides, and take a little bit more time on your own to go through these, you're seeing all these things that really everything's been coming out of the military, where a lot of our background is. Now, as we get a little bit closer to the 20th century, I'm going to talk about a lot of things that have changed and what's important here. So the big thing came to transporting, and actually a long time ago, it was actually physicians who were on the ambulances. Started out from the if you think of the old days of the Western, it was the doctor that rode out and did the house calls, and that's who it was. And so they were originally, the ambulances was actually a couple of doctors, um, and that's what started it. And then we started coming out to an area what's more practical, what's a way that we can increase this, and that's kind of changed to the EMS system we have today. So the thought process is, let's get a standardized system of how we can treat people and across the country and what we do. The Accidental Death and Disability Act, basically, or what's called as the white paper, that was our chance for the physicians really to get out and decide what's going to be consistent. And that's really kind of what started the flow, is that white paper act is started of developing and researching EMS and what needs to be done to make this a standardized. In 1966, the National Highway Safety Act, which really comes up with most everything to the DOT we talked about, is saying let's get something standardized. So they talked about this. They started going out through the systems and making EMTs instead of doctors on there. And then about 68 is when they started bringing up the paramedics. That's when we really started coming in and get into the EMS field. For those of you who remember back, what really started and promoted paramedicine was the show Emergency with Johnny and Roy and popping the tubes up and using epinephrine and the cardioversion with defibrillation with the paddles. So that's what really pushed paramedicine across the country and was kind of the standard. It was definitely a mother may I state, which what California is, but that really kind of pushed it. In the 70s, basically, that's when the National Registry came out. We needed a body that was going to regulate and control the standards of how EMTs and paramedicine was taught across the country. This was also done basically in a regulatory manner and basically getting testing, but there was not quite of a standard yet. we did start to see really in the 80s where we started coming through and really kind of pushing those things of PHTLS, how we get the treatments, where we needed to be at. In the 90s was what brought us around to getting the standards of here's the curriculum that needs to be taught throughout the country. Granted, some places have different accesses to different things and we have different protocols around there, but here was a standard that had to be set as a minimum standard, and that really pushed that. And that's where we've kind of gone through. One of the things that we've seen of changing even more with us is, again, as the climate changes, to mass casualty shootings, to bombings, to everything that's out there has really changed things to where we got this standard and brought into NIMS and ICS. Now we've gotten to the point too where we are really trying to increase our protocols, increase our testing standards, and making sure all the schools are keeping up to those levels. Here we talk about the national report card of where we're coming. Even today, we're changing what we're doing with CPR to get our saves. We're always constantly adding. We're constantly increasing the ability of what we need to do. We're getting a lot of hospital involvement in the pre-hospital setting as far as teaching and saying what they need to do, so we're getting those cross efforts. You look at this, and this was a report card of where we're at. We actually did very poorly how we were acting in the EMS field with the pre-hospital and getting things set. Well, now we're seeing a big change with that. For us in this area, Seattle has been huge with their Medic One program, pushing a lot of our standards, and we pushed that into Spokane. So we're seeing a lot of changes in what we're doing. We're seeing that we're going to push EMTs to be knowing 12 leads here soon and performing 12 leads, not necessarily reading them, but performing them. We're also requiring a lot more of our medics today of what they do and standards. So kind of today's EMS, what you guys are getting into is we have mostly EMTs and paramedics pretty much are the fire base that are going. Some areas that we have will transport, some are non-transporting. We're going to basically try and coordinate all our care, basically get those in, and we're trying to get that higher level of care there as quickly as possible. And we're using science-based, we do as AHA, and doing studies, and we're keeping strict information on all these patients and all the events so that we're actually making decisions based on science, numbers, and what we're seeing. Our medical directors are stepping in. They're supposed to be doing more, staying on top of things, and we've increased protocols in a lot of areas. So people are able to have a bigger protocol to go, but they always have the backup of getting online, calling the doctor at the ER, and getting more direction, or basically what we call offline medical direction, to go above and beyond the protocols. Especially with us in Spokane County not transporting dead people, we'll do that a lot of times of doing those. Again, we still based it on what do we see, our triage of that, what treatment we need to do, where do we need to transport, how quickly, and are we going to be transferring care. The other aspect we've done is we've been teaching hands-on CPR only to the public, and the more we can do with public education, the better we're getting for saves out there for them to know what to do. They can recognize what the emergency is. They can actually start the CPR. They can start healthcare immediately before we get there, because a lot of times our responses are 2 minutes. Now we're coordinating with that. We're requiring our 911 operators to be able to give that information and tell even a layperson on how to do and start care, bleeding control, safety, all sorts of things that they can be doing to take care of that patient for that 2 to 5 minute response time we have depending on their area, and sometimes longer in bigger areas. We're doing a class-based here, but there's also a lot of continuing education that can be done online, everywhere else, so we're keeping it up. Again, once you get out of here, we're going to make sure that you have your initial education, get all the information you need, but we're going to require that you maintain that. And we'll talk about what National Registry requires to maintain that certification. Because once we get you through here, you'll apply for your licensure within Washington State, Idaho State, Oregon State, wherever you go, and get that. And then once you have that, you're going to maintain it. Of course, we all know about different levels, and we've kind of changed there to throughout the years of what type of levels we do have. And then we're going to be regulated not only by the national level, but it's usually your state level that's going to regulate your certifications, your education, your experience, and your protocols that you're going to do besides your local area. Now, once we do have you certified, you're going to have to continue that certification. There's a couple different ways you can do that. We have 48-hour refresher courses. We have classes that you can take, and then the OTEP classes and other continuing areas. National Registry is basically going to be our big area that's going to maintain your registry site, and it's trying to be a standard so you can go from state to state to state and keep that reciprocity and that transfer over there. Other excuse me, other areas you can go into is critical care transport. You can get into industrial occupational medicine. There's tactical EMS that's done. There's areas in the hospital that can be set up, and even in cardiology's offices. A lot of things, roles you can play in an EMS. And then becoming a part of these organizations is basically a way to keep informed. So staying with the National Registry, getting these updates of what's happening on different letters, articles, and that is going to keep you so that you're not losing things, but you're always learning and growing. Some of these different associations you can be as the National Association of EMT, Search and Rescue, EMS directors, physicians, Paramedic Association. There's a lot of different things you can get into to maintain those areas and keeping that information going to you, as well as all the journals out there, EMS Online, different trauma journals and things like that that always continually reading. There's always something to learn and go on, and especially the online stuff is some of the newest stuff out there, which is great to stay on top of. Other journals that you can look in for more advanced information, obviously, is the medical journals and those journals that the physicians are using, besides some of the emergency medicine and EMS world. A lot of different ways to keep up on top of things, and we're going to have you guys delve into those as well. As far as our patient transport, it's going to be making those decisions. Where at hospital do I need to go? What about the closest hospital? When do I divert or bypass a hospital? What are my areas and times that I go to, and knowing those hospitals that you're going to transport in and how you're going to transport them. Here we're going to talk about the different kind of ambulances that are out there, and we'll talk about those different specs of a type 1, type 2, and a type 3 type ambulance that you'll see. So a lot of different standards that come in from those. We'll talk more about these when we get into ambulance ops. But I just kind of want you guys to be aware of what's out there and realistically what's in your system that you're going to be working with. All going to be big things for you. So our type 1 ambulance is traditional, going to be the conventional cab and chassis. It's the ambulance in the back, and it's kind of a truck chassis that you're going to see. And it's just got a box, but instead of like the standard brush trucks we have, it's got a box in the back. The type 2 is going to be that van body or the unibody. And the type 3 is what we're really seeing around here, is what AMR is running right now as our type 3 styles. The type 3 can also come into a heavy body, big diesel type truck, which we don't see too many of those out there. MedStar does have one that they run. So we're going to basically make sure that we're keeping up on which hospitals we're going to be going to and the standards that we're going, because not all the hospitals are going to be the same. What Deaconess freestanding ER can take versus sending someone down into level 2 trauma center, which right now is Sacred Heart and Deaconess is attempting to be there, is going to be different things versus Valley Hospital and what they can handle. We have to know our specialty hospitals. Obviously, we're going to be going to Harborview for our burn patients and for our level 1 trauma patients. We have a pediatrics at Sacred Heart, but we need to know where we need to go and take these patients. And that's all going to be a part of you knowing your EMS system. When do I need to fly a person? What flight companies out there can I use are going to be available for my area? And knowing those services in your area is going to always be the big thing. System financing, again, it's how areas go and whether you're a city department or that. I'm not going to get too much into that because I don't think that's really kind of a part of our level from education there. So, and you're not going to be tested on any of that. But it is knowing from where you live and the areas on there that you need time is that critical area. And when we go to PHTLS, we'll really talk about that and thinking of those air resources. Even if it's a 45-minute trip, sometimes that's going to make a huge difference from having a helicopter there versus not. And we've actually had a couple times on here where we've got a helicopter from Fairchild, didn't have a medical crew, but they would come out and pick us up as a medical crew to fly on their chopper. So we have a lot of different aspects that are going to save on time. And for our real critical patients that need to go over to Harborview, a lot of times we're going to transfer those over to a fixed wing. And that's taking them down to Phelps Field, get them into a plane that can take them that long distance, fly up higher above the weather and everything else. So that's also a part of our system and what we use. That's the biggest thing, is knowing what's in your system to bring everyone together. So we work together and we know everything that's in there, especially when we talk about these mass casualty incidents and preparedness, which we'll talk more in class. Hopefully this gives you a brief overview of what you're going to